Conrad, and I apologize, there was some issues with the sound that, during that presentation. But one of the things, the questions I've got, Conrad, is they couldn't download the forms of the protocol. Can you put up that web address again, please, while I ask you the next question?
Yeah,
So
no problem. Yeah, the thing is, it's in the EFSOM, www.efsom.org, or they can send me an email right away.
Okay. The other question I have is, do you put ultrasound gel also inside the covering of the bag transducer? What type of transducer do you prefer? Those are the two questions I have.
I'm completely I completely understand this question. This was exactly what I was showing in the video without tone. I was telling that it's important that you put, if you're wrapping up the ultrasound machine, that you put gel on the transducer first and then wrap it up. Otherwise, you don't see a thing. This is especially very sad if you perform endorectal scans. And the thing is, if you are, if we're working with gel in the ICU, we've got the bottles with the gel inside the room. They stay there, and we don't put them in another room. And it's also good for follow-up. And another thing for follow-up, if you have a region, only few region, like with this very old guy, we just take a heading marker, just a text marker, and so to say, we mark the places with the biggest changes of the pleura, or with the biggest consolidations, and then we really can follow up these regions. What kind of transducer? The thing is, normally, because of we want to have B-lines. B-lines can just be seen with the curved transducer. So we're using normally the curved transducer, but if we're not sure about fluid changes, we go on to the linear transducer. And if you have a pocket ultrasound device, which has normally got a much less attractive B mode picture than the new machines, you can use the linear transducer right away, because you would see the B lines because of that technology very easy. So if I use my handheld, I just take the linear transducer, and this is completely sufficient. All pictures you've seen were done with this linear transducer.
I have another question, Conrad. In each of the 6 areas, you remain in an intercostal space and scan up and down, or you scan each and every intercostal space?
Well, what I do is I go. Some call it in Germany the Moa, the Moa technique, where you where you go each intercostal space. What I normally do, I go into the intercostal space and move my transducer. Like I wobble a little bit with my transducer alongside the intercostal space. And the thing is, there is mostly a limited number of windows for the ultrasound exam. So normally it doesn't take a lot of time to do that.
Okay. I think that's the end of the questions, and thank you very much, Conrad. We have to move on to the next speaker. Hang on, I've got another question. Okay, let's see what it says. We are talking a lot about areas, protocols, and ultrasound systems. There is confidence about that, but do we have a full consent of tactical aspects? Should we turn off any cosmetic filters, such as compounding, to clearly visualize the pleural lines? What do you say about that? Are you turning off compounding?
Question to me, Paul?
Yes.
Yeah. The thing is, I turn everything off. I want to have nearly a nude ultrasound picture. I want to have the ultrasound picture of the 90s. All kind of compounding, all kind of spatial resolution thing, all kind of sonus CT. Put it off. You don't need it, because it destroys the artifacts you need for the diagnosis.
Yeah.
Very important.
And another question is, well, if you're doing lots of lung ultrasound in any ITU patients, you've got all these different images anyway. How can you really diagnose COVID, or are you depending on the clinical picture as well?
That's why we're doing this multi-center study. And in our multi-center study, we just not only doing ultrasound pictures, we also add clinical data and lab findings to correlate. I think the future would be that we would have the ultrasound for the follow-up, that we have the CT for the first localization, and that we providing the COVID-19 diagnosis by ultrasound only is very hard. By the way, also by CT, because we had a very high pre-test probability for COVID-19. So the CT was very good in the first place, but now it's getting more and more difficult because we're also having other kinds of viruses, influenza, RSV or something like that, which is quite similar. So the pre-test probability is going down. For COVID-19, we would have some clinical signs, we would have some lab findings. I think the D-dimer test would be one of the highlights there, and we have the ultrasound picture. But doing ultrasound saying this is COVID-19 would be impossible. But doing the ultrasound and saying, okay, here's something going on which is really affecting the lung, as really might be a virus pneumonia. This is what we could do, and in the end of the study, this is what I hope will be one of the conclusions.
Okay, I'm going to have to draw a conclusion to the talk. There are some other questions, but we'll have to move on here. Thank you very much, Conrad.
Thank you very much, Paul, and thank you all very much for the kind of.
Thank you.